Great stuff. Okay, super. So just to remind everyone, the power course is on those dates. We've got four dates, each of which is 2 hours duration. It's 7 till 9 o'clock GMT, and we'll be conducting it between the 20th of Feb and the 12th of March. More details will be seen on radiologymasters.com. It's not out yet, but it will be in the next few days. So visit that website and you should get all the information you need. Okay, first film. This is quite tricky because when you do the FRCR exam, the chest x-rays can sometimes look normal. And if you look very carefully, you can see that there is an outline of a lesion here. Now, it's much clearer on the lateral view. And the reason why it's less clear on the frontal view is, of course, it's projected below the dome of the diaphragm, which is just here. And sometimes you may need to invert the image. And inverting the image, I think you can see it's a bit easier to discern the lesion. And if that makes you more likely to pick the lesion up, you must do it. So use everything you've got in your toolbox to pick up the lesion. Now, why can you see the diaphragm, and why does this appear below the diaphragm? Well, simply it's because the point of contact of the X-ray beam with the diaphragm is tangential at that point there. And the lesion is below the ray that is tangential to the point of contact. And therefore, if that's the diaphragm on the detector plate or the cassette, the lesion's going to be below the diaphragm. But anatomically, of course, it's above the diaphragm. So that's the reason why. So whenever you see a normal looking chest x-ray, don't forget to look below the diaphragm for any lesions which are in the lung but are projected below the diaphragm. Okay, this patient has got a cough and weight loss. Right lower zone nodule, possibly. Left lower lobe collapse, no. Right upper lobe collapse. The right upper lobe collapse is so tight that it's just widening that paratracheal stripe, but it's in a straight line. And we've got pulling up of the hilum. So the hilum should be here, and now it's been pulled up to here. So there's been pulling up of the hilum, and the left hilum is okay. And somebody commented about a possible nodule here. Could be right, but note the tenting at the insertion of the inferior pulmonary ligament also. So this is a right upper lobe collapse, and it is causing a tight right upper lobe collapse, and it's due to an endobronchial tumor. Okay, this is a left lower lobe collapse. Okay, and there it is, the sail shape behind the heart. There's volume loss in that left hemithorax. And when you do the CT scan, of course, the left lower lobe collapse, you can see the interface on the frontal projection because the X-ray beam is tangential to the interface between the solid left lower lobe collapse and the hyperexpanded left upper lobe. Okay, so left lower lobe collapse. Okay, what is wrong with this patient who has got high blood pressure? Bavia Bassetti was instantaneous off the blocks, and we can see here neurofibrometer, and there's a neurofibroma just there. Why might this patient with neurofibromatosis have high blood pressure? Well, they could have essential hypertension like everyone else. They could have renal artery stenosis. They could have a pheochromocytoma. They could have coarctation because neurofibromatosis is associated with coarctation. Asthmatic on steroids, there's some middle lobe collapse or consolidation just here. That looks to me like a VP shunt. And we've got avascular necrosis, probably caused by steroids, secondary to asthma. Okay, what do we call this on the chest X-ray? There's the aortic knuckle, there's the left subclavian artery, and we've got the left superior intercostal vein, and this is called the aortic nipple, okay? And the aortic nipple becomes more prominent when this becomes engorged in SVC obstruction. This patient also happens to have an aberrant right subclavian artery, but that's called the aortic nipple. And in a different patient, there's the aortic nipple, and there it is on the chest X-ray. Normal variant, but it does become exaggerated during SVC obstruction. Okay, this patient has got a pleural-based tumour. There's a cavitary lung tumour. There's volume loss in the right hemithorax. And what else is there in that lung? Lymphangitis. That's right, lymphangitis. All these thickened septal lines. Lymphangitis carcinomatosa. Okay, we've got a chest CT with cavitating pulmonary nodules. What is the differential diagnosis? Well, it could be Langerhans cell histiocytosis. It could be Wegener's granulomatosis, or as we now call it, GPA. It could be metastatic squamous cell cancer from cervix or head and neck. It could be multiple rheumatoid nodules. It could be fungal pneumonia. If they were larger and more peripheral, they could be cavitating infarcts. If they were associated with contusion, you might think about traumatic pneumatoceles. And if they were larger and associated with ground glass change in the upper lobes, you might consider pneumatoceles secondary to pneumocystis. So whenever you get something like this in the exam, you really do have to know quite a number of causes because the examiners will know those causes. And you've just got to have your pathological sieve and know that you could be dealing with inflammatory change, neoplastic change, etc., etc. Now, here is another cause of cavitary lung lesions. And there's a big cavity up here, and another big cavity here, and one behind it. And then there's consolidation just there. And you'll notice that the aorta is here, and the pulmonary trunk, instead of being like there, is now convex outwards. So we've got pulmonary artery hypertension, we've got multiple cavitary lesions, we've got a pulmonary infarct that is about to cavitate, and so you can use the X-ray to work out exactly what the cause is. So in the previous case, it was a differential diagnosis of about 5 or 6 things. But in this case, there isn't really a differential diagnosis because whatever's going on has caused pulmonary artery hypertension. And so the one diagnosis that fits everything is thromboembolic disease with cavitary infarction. Okay, normal variant. Can the college show you normal variants even though it's the 2B? Yes, they can. It's not a pig bronchus, okay? It's not a pig bronchus. So that's the right upper lobe bronchus. There's the bronchus intermedius. What's that bronchus there? It's heading off that way. Yeah, it's the cardiac bronchus. There it is, it's the cardiac bronchus. You don't see them very often, quite rare. Okay, this patient has got breast cancer. What's going on? They've got sclerotic bone mets, and what do you think's going on in the CBD? They've got metallic stent, so it's likely that they've got intrahepatic metastatic disease, which is causing extrahepatic cholestasis by pressing on the bile duct here. Okay, this patient is complaining of back pain. Please show the cardiac bronchus again. I will do after this case. Yeah, the left sacroiliac joint is okay. It's the right one that's abnormal. So if you have unilateral sacroiliitis, what is the diagnosis? It's almost always infection. Now, it can be seronegative arthropathy, but it's almost always infection that causes unilateral sacroiliitis. Right, the cardiac bronchus again. If I just delete the ink, there you go. So there's the right main bronchus, right upper lobe bronchus, bronchus intermedius, right lower lobe bronchus here. And what we don't see, which is more anteriorly placed, is the right middle lobe bronchus coming off, okay? But this is the cardiac bronchus and it goes off towards the heart. Don't worry about it too much because it's incredibly rare. What is the cause of the biliary stent? It's, yeah, Zoe Winston has just answered it. You've got extrahepatic compression caused by intrahepatic metastases. So in other words, the stent is because we've got stenosis due to extrinsic compression due to metastatic liver disease. Okay, hypertransradiant lung. How do we deal with it? Number one, we identify that it's hypertransradiant. The next thing we do is we count the number of vessels, and the number of vessels per unit area here are, for example, 30. I'm not going to count them, but just say they're 30. Well, on this side, they're probably about 15. So half the number of vessels, and therefore this is the abnormal side. And it's a lung problem. Okay? Whereas if the number of vessels were equal on both sides, you're dealing with a chest wall problem. But the vessel reduction is due to the fact that it's a lung problem. Now, I can see the hilar point. I can't see the hilar point on the left side. And in fact, the left hilum is hypoplastic because it is tucked behind the heart border. And this is most likely to be Swyer-James syndrome. Now, some people say, could this be a left lower lobe collapse? I suppose it could, but it isn't. This is just pericardial fat, just here, and these are just vessels. So it's not a left lower lobe collapse, but it's Swyer-James syndrome. And if you ask the patient to do an expiratory excursion, this would either stay the same or get bigger, and this would get smaller, and that's pretty much in keeping with the diagnosis. It's really, really important, though, to notice that when you do the expiratory view, that is not the end of the story. You do still have to exclude an endobronchial tumour, because endobronchial tumours can actually cause air trapping of this magnitude, especially something like a carcinoid tumour. So you can't diagnose Swyer-James syndrome just on the chest X-ray appearances alone. You have to get a positive history of bronchiolitis as a kid, and if you don't get that, you need to explore further the fact that they don't have an endobronchial tumour. Okay, young lady with sinusitis and hemoptysis. Yeah, GPA. It's a slam dunk, isn't it? GPA. And GPA, you tend to get very shaggy peri-lesional change with consolidation around it. There's nerve fluid level in one of them. And these are all cavitating vasculitic lesions in the chest. Okay, this is the same patient. What have we got here? Yeah, and you can see that we've got no formed feces. So we've got a total colitis. We've probably got a stenosis here. You can see that the bowel wall is thickened, and we've got mesenteric fat infiltration. So this actually was ulcerative colitis. Okay, male patient with a deformed femur, 35 years of age. GPA is granulomatous polyangiitis, or polyangiitis with granulomata. It used to be called vagus granulomatosis. Okay, so what have we got here? 30-year-old guy with a deformed leg. Diaphyseal no. Would that explain the soft tissue here? No, not really. It looks as if we've got a fracture which has healed badly, deformed fracture. And we've got new bone formation in abundance. And it just looks the most bizarre thing you've ever seen. Here's the MRI scan. There's the soft tissue with heavily T2 weighted gradient echo sequence with lots of hemosiderin. There's the T1. Nope. Lots of hemosiderin. What does that make you think of? Spiky bone. Spiky bone. Hemophilia. Yeah. Hemophiliac pseudotumor. Now, everyone, remember this. If you get this in the exam, think about it. Male patient, lots of soft tissue swelling, lots of new bone, which is spiky, and you may get pathological fracture through the bone, and you've got a lot of hemosiderin around. It's hemophilia, hemophiliac pseudotumor. Okay, this patient's got a cough. What do you think? Pectus excavatum, brilliant. Anything else? Yeah, there's a Pancoast tumor in the left upper lobe. Yeah. So Pancoast tumor is causing the problem up here, and this is the pectus excavatum. So there's the sternum, and it should be here. So there's definite pectus, which is causing this change here, but don't forget there could be a Pancoast tumor here. And so when we did the CT, obviously that's the pectus excavatum. And there's the Pancoast tumour, which is already eroding the bone just here. So if I go back to that, there's the Pancoast tumour. Here is the pectus excavatum. And sometimes you get two pathologies on one film, which are unrelated. Okay, so Pancoast tumour, very difficult to spot. And often Pancoast tumours present very late because, of course, you've got very subtle radiological signs. Okay, costochondral junction, popcorn calcification at the costochondral junction. There's lots of popcorn calcification in the scapula. Looks like a enchondroma, and there's multiple enchondromas. So Ollier's disease, except when you do the hand X-ray, it's not Ollier's disease, it is Maffucci's. Yeah. And how do you spell Maffucci? Okay, Maffucci. Two F's. And oh, actually, I've spelt it wrong. There's another C. Two C's and two F's. Okay, Maffucci. And these are phlebolyths, and they represent hemangiomas. There's a Madelung's deformity and lots of enchondromas in all the bones. Chest pain. And this is a close-up showing sclerotic bones. What do you think of that vertebra there? H-shaped vertebra. All the other vertebrae are normal shape. Can you get one abnormal vertebra in sickle cell? Yes, you can. And this is at the H-shaped vertebra. Now, why do we get okay, so that's normal, and we've got end arteries, and then in the periphery we've got I'm gonna have to erase that. Start again. So we've got end arteries, there, and we've got a network of capillaries at the end of the end plate. So the periphery of the end plate has got all this capillary network. So if you get sickling of cells in the capillaries, you've got 1,000 other capillaries to supply the blood to the periphery of the end plate. But if you knock off the end plate by virtue of the end arteries, the bone becomes infarcted here. And then over time, that becomes an H-shaped vertebrae as the weight of the patient compresses down on this soft bone, causing the H-shaped vertebrae. More sickle cell disease. Lots of H-shaped vertebrae, which you can see very nicely. We've got a spleen, which is small and calcified. We've got avascular necrosis of the left femoral head. We've got some form of orthopedic procedure. Total hip replacement has been taken out of the right hip. And this is an operation to sterilize the joint in preparation for a revision arthroplasty. So you'll also notice there's a right pleural effusion there, and there's a what looks like a double lumen neckline. So we've got one limb there, double lumen neckline, right pleural effusion, small spleen, which is calcified, avascular necrosis. That hip replacement is probably avascular necrosis also. And then we've got H-shaped vertebrae. So a very nice demonstration of sickle cell disease. Two other things that you might see on the X-ray, although you don't in this one, gallbladder, you might see stones or clips, and you might see renal stones. Okay, so that's about the sum of what you might find in sickle cell disease. The renal stones are from sloughed papillae in patients who've got renal papillary necrosis. Okay, while we're on the subject of avascular necrosis of the hip, there's another example of AVN with flattening of the femoral head there, and this is an ileostomy bag. So the patient has been on steroids for ulcerative colitis, and they developed AVN of the right femoral head. More avascular necrosis of the femoral heads here and here. And the surgical clips, they could be on the right side or the left side, indicate a renal transplant. So whenever you look at a patient who's got avascular necrosis of the femoral heads, you just need to remember that there are a number of causes, and you should look on the film to see if you can see those causes. So, for example, ileostomy, ulcerative colitis, steroids, ankylosing spondylitis is associated with taking NSAIDs, which again can give you avascular necrosis. A renal transplant, obvious steroids and immunosuppression. Patient may have a big spleen, in which case they could have Gaucher's, or a myeloproliferative disorder, which makes your platelets sticky and your plasma viscosity high, and then sickle cell disease. I'm very grateful to Dr. Rohit Sharma from Delhi for sending me this. By the way, if anyone wants to send me any cases, I will always include them here. If you want to send them to me at my email address, and I will post them and I'll give you the full credit. So anyone who's interested in sending me an interesting case for the Viva, or might even be the long case, you can send this to me. So the patient's got multiple metastases here, there, mixture of sclerotic and lytic metastases, and there's no breast shadow on the left-hand side. So, mastectomy with bone mets. Okay, the best example of eggshell calcification you will see on a chest X-ray. Eggshell, eggshell, eggshell. And there is a differential diagnosis for this. Could be due to silicosis, could be due to sarcoidosis, and you just need to look at other features. Okay, the other causes are treated lymphoma, amyloidosis, and scleroderma. So most of the time it's going to be due to sarcoidosis, simply because sarcoidosis is much more common than silicosis. Okay. The other causes are less common, so the treated lymphoma, scleroderma, and amyloidosis are much less common. Diagnosis. Central lucency. Yeah, vascular malformation is a good answer, actually, but these are multiple hemangiomas of the forearm. Yep. Okay, what's the diagnosis here? Yeah, fibrous dysplasia. And what might the patient look like clinically? A lion face, yeah, leontiasis, ossea or leonine facies. Yeah, comes from the Latin for lion, which is Leo, and that's why we call lions Leo the lion. Leon, Isis, ossea. Okay, what's the diagnosis here? Thalassemia, yeah. So we've got hair on end appearance. The inner table is pretty much okay. The outer table is thinned. We've got opacification of the maxillary sinuses, and these are the maxillary sinuses just here, full of hemopoietic tissue. Thalassemia. Relative non-involvement of the occiput because there's a paucity of bone marrow in the occiput. There's another instance of thalassemia. This patient actually does have a bit of bone marrow expansion in the occiput, just to prove me wrong. There's the posterior pituitary, which is high signal due to neuropeptides. There's the anterior pituitary, and you can't see the maxillary sinuses because this is a true sagittal T1 weighted image. Okay, onion skin, testis, epidermoid. Yep, brilliant. Okay, what have we got here? Yeah, von Hippel-Lindau syndrome. Why has the patient got a prosthetic eye? Yeah, retinal vascular malformations, whether they be angiomas, hemangiomas, whatever. So the patient's had a prosthetic eye due to retinal pathology, and they've got this cerebellar hemangioblastoma with a mural nodule which is enhancing, and they've got a mural enhancing nodule, but without too much in the way of a cyst. There is a small cyst just here. Von Hippel-Lindau syndrome. Now, I don't know whether you can see this very clearly, but there are surgical clips here, and we've got multiple miliary and larger than miliary nodules. What's the most likely cause of these metastases? Thyroid cancer. Well done. So whenever you see lots and lots of lesions in the lung like this, tell the examiner you're looking for surgical clips or for a goiter, or you might want to look below the diaphragm for nephrectomy clips in the event that this is due to metastatic renal cell cancer. Okay, what have we got here? It looks a bit like HPOA, and to be honest with you, if you said this was HOA in the exam, I would have to agree with you. But in fact, it's thyroid acropathy. And to be perfectly honest with you, there's not a great deal of difference, I don't think, except if you look here, the nail fold angle is just preserved, whereas in somebody who's got clubbing, you would see the nail fold angle becoming like that. Okay, so if that's the nail and that's the skin, it would be like that. So the findings are periosteal reaction, very similar to what you might find with HOA. In this particular case, there's not much in the way of MC involvement. It's mainly phalangeal involvement. Whereas I think with HOA, it would affect the metacarpals more than the phalanges. Whether or not that's a significant distinctive finding, I don't know. And in fact, if anyone knows the answer to that, perhaps they could let us all know. But thyroid acropachy looks very, very similar to HOA. Oh, sorry, you've seen that one before. Hemophiliac arthropathy. Okay, this is a young patient, adolescent, and the answer to the last case was thyroid acropachy. So we've got a young patient, we've got what looks like a tunneled line, and we've got a nodule just there. There's the nodule. So put it all together. So why has somebody got a tunneled line? Yeah, it's a metastasis from an osteosarcoma. Okay, now it could be from anything that gives you cannibal lesions, but it just happened to be an osteosarcoma. Now, there is a slight difference between the right humerus and the left humerus. Whether or not that represents a sarcoma remains to be seen. It's certainly worthy of another view. Okay, we've got a lesion in the spinal canal. Yeah, it looks like a meningioma. There's the dural tail. Yeah, and it's an obtuse angle, flat based, and that dural tail, which is a telltale sign for somebody who's got a meningioma. And that's what it was. And there's the meningioma here, which is causing cord compression. And that needs to be taken out. Now, meningiomas classically occur in middle-aged females. Okay, middle-aged females. And it's usually mid-thoracic, but obviously you can get them in the neck as well. Okay, this is a bronchogenic cyst, very large cyst, which molds to the surrounding structures. It's in the middle mediastinum because the epicenter just there is in front of the anterior longitudinal ligament, which is just there. So it is centered in the middle mediastinum. There's the posterior mediastinum. And so this is in the middle mediastinum, and it's a cyst. It's just below the carina. It's a bronchogenic cyst. Okay, this is a young guy who unfortunately died before he could get into the CT scanner, but he's got an ET tube in situ. It's a supine film. He's got widening of the mediastinum, and the mediastinum can't get any wider because it's a certain space. And so when it can't get any wider, the blood just pours out over into the superior sulcus in an extrapleural fashion. We've got a fractured clavicle up here. We've got contusion in the lung here. And this really is the apical cap, which tells us that there must be a significant intramediastinal injury. And so what we've got is we've got the parietal pleura in green, the visceral pleura in blue, we've got the aortic knuckle, we've got a transection of the aorta. It doesn't have to be full thickness, it could just be involving the intima and the media, but you get hemorrhage in the mediastinum, and that spills out over into the extrapleural space above the parietal pleura, and that's called the apical pleural cap, and it's a sign of severe aortic trauma. Okay, we've got pulmonary fibrosis, which is predominantly at the bases. We've got a dense liver, okay, compared to the spleen, and we've got a left ventricular aneurysm. Yeah, so patients on amiodarone because they've got an arrhythmia, and the amiodarone has caused pulmonary fibrosis, as well as being metabolized by the liver. It sends up the attenuation value of the liver. Okay, this patient presented as a stroke, and his GCS has gone from 10 to 3. And what can you see? Yeah, basilar artery thrombosis. You can also see some low attenuation change here. And this patient has got posterior territory infarction and probably would not be a good candidate for thrombectomy. But always worth having a discussion with the clinician and the neuroradiologist. Okay, patients had an old infarct in the past with ex vacuo dilatation of the ventricle, and they've got an occipital infarct now, so they're going to get cortical blindness. Now, whether or not it's worth doing a mechanical thrombectomy can't be decided just on the radiology alone. You've got to have a discussion with the clinicians and the interventional radiologists concerned. Okay. What's going on here? It's just a close-up of a patient with ARDS, and the patient with ARDS also happens to have a Swan-Ganz catheter in situ, which we don't see very often anymore. Swan-Ganz catheter is really designed to measure the pulmonary artery pressure and the pulmonary capillary wedge pressure. So what you used to do was float this into the pulmonary artery, and we would then take the pulmonary artery pressure readings. But that is really a historical thing. But what we've got here is pneumomediastinum around the heart in a patient who's got ARDS. Okay, there's the pneumomediastinum. Okay, so I'm going to leave it there. But what I'm going to do now is I'm going to just put up the schedule for